Welcome everybody, thanks for tuning in. This video is a mix of general block-related information as well as UW-specific details that you need to be familiar with to do these procedures safely and effectively. The ED nerve block program has two major goals: providing our patients with access to optimal non-opioid analgesic strategies as soon as possible after their arrival in the emergency department, and also to teach our residents these skills so that they can make use of these modalities throughout their eventual careers. I don't think it's controversial to say that eventually ED performed nerve blocks are going to be standard of care for many patients who come through our doors. Everybody who works in an emergency department is already doing nerve blocks. They're bread and butter emergency medicine. By adding an ultrasound to the mix, we can greatly expand our abilities to hit different targets. Whereas you may only have experience numbing ears, teeth, and fingers, using point-of-care ultrasound, we can anesthetize pretty much any body part reliably and safely. While we love our anesthesia colleagues, the reality is that we are the ones who are at the point of care 24/7. There's no shortage of data that supports doing nerve blocks early and often. This is certainly not an exhaustive literature review, but I wanted to highlight a few examples. Studies show that patients who receive a nerve block in the ED have less pain, consume fewer opioids, and develop delirium less frequently than those who do not. One study has even shown a decrease in length of stay for those who receive a nerve block in the emergency department. Imagine a 90-year-old patient with dementia who presents to the EMH emergency department at 7 p.m. on a Friday with a hip fracture. That patient's not going to see an anesthesiologist for at least 12 hours. These are the patients for whom I think that we can do a better job as a department and system. The benefits extend beyond hip fractures. An RCT in 2011 showed the interscalene nerve block for shoulder reductions decreased ED length of stay by 77 minutes from 177 to 100 minutes. The group receiving a sedation averaged 47 minutes of time with a provider in the room versus only 5 minutes for the nerve block group. This means that you can free up 42 minutes on a busy shift by reaching for an interscalene nerve block over procedural sedation for a tricky shoulder reduction. Additionally, the erector spinae plane block is quickly becoming a workhorse in emergency medicine. It provides analgesia to the entire hemithorax and much of the hemiabdomen. It's been shown to be extremely effective in the pain control of rib fractures and decreases opioid consumption in those receiving this block for this indication. The uses for nerve blocks in the ED continues to grow. Specifically for the erector spinae block, not only does it spare patients from the pain of rib fractures, but it's also been shown to provide relief from pancreatitis, low back pain, cholecystitis, and even renal colic. These are all notoriously painful conditions that we see every single day in the emergency department. So what is this process going to look like in our department? The first step is to identify a patient who would be appropriate for a nerve block. Hip and rib fractures are common injuries and both have an effective and safe block, so these should be on your radar as potential good candidates for a block. We've developed protocols for both of these blocks that you can reference on Madtown-Sano, but please don't think that these are the only two indications for ED performed nerve blocks. I've made instructional videos for multiple other blocks that you can find on Madtown-Sano that can help you manage shoulder dislocations, fractures, and lacerations of the upper extremities as well as additional lower extremity injuries. Once you've identified an appropriate patient, the next step is to complete the consent process as you would for any other ED performed procedure. We're used to consenting patients for needle-based procedures. This includes the standard risks of pain, infection, and bleeding. However, when it comes to nerve blocks, there are a couple more unique risks to warn patients about. Specifically, we want to talk about peripheral nerve injury, damage to surrounding structures, and also local anesthetic systemic toxicity, or LAST. And we're going to talk about each of these three on a later slide. The next step is to calculate your maximum dose of your local anesthetic, and this will be specific to each patient you perform a block on. I recommend either the Safe Local app or the MD Calc app for this. The next step is going to be to enter the orders from the ED nerve block order panel. We've put this on the chief complaint panel on the far left side of our quick list in the emergency department for easy access. This will pull in all the orders that are necessary from a nursing standpoint, as well as the PRN orders for the intralipid in case of LAST. The next step is going to be for the provider to inform the EDRN of the plan of care, gather the block supplies from the block box. To make it even easier to complete these procedures on a busy shift, I've made a block box which will live in the south side dock box as well as on the ortho cart at EMH. Basically, you should be able to order your anesthetic, grab one of each thing from the box and an ultrasound, and you should have everything you need. Please, please, please save your images for these procedures. Do this the same way you save any images from any other ultrasound study. Enter the patient MRN or find them on the work list, and then enter your HealthLink ID before you start scanning. You will need someone to hit the record button because the operator is going to have sterile hands. On the Mindray machines, there are buttons on the linear probe that allow you to change gain, depth, and save clips while remaining sterile, but unless you're doing these procedures frequently, it may just be easier to recruit someone to push the record button for you. You can also manually adjust the duration of the clips so that you can just hit record once and record the whole procedure. The ultrasound team will QA all the submitted nerve blocks and give you tips and can help you troubleshoot why a block may not have worked as well as you hoped it would. This step is vitally important. So as the patient performing the block, you are the one who knows how much anesthetic goes into the patient, where, and when. It's imperative that we do this in real time for the benefit of our colleagues who will admit the patient down the road. This will be particularly important for patients who end up being admitted to Meritor. Some of these patients will go to the OR, and anesthesia will need to know when and how much local anesthetic was given so that they can do their jobs effectively. The nerve block note lives with the rest of the note writer templates when you open up a procedure note as a standalone or as part of your provider note. If you do decide to include this as part of your provider note, make sure you then complete and sign your provider note in real time. We've made the volume administered a hard stop to ensure that this is filled out. Again, from a systems perspective, this is the most important part of the process so that everyone down the road knows exactly what was done. So how do people get quote-unquote signed off to do these procedures? The short answer is that all of you are already credentialed to perform these procedures. Specifically, UW gives us the privileges to evaluate, including performance of H&P, diagnose, and treat patients presenting with any illness, injury, condition, or symptom to the emergency department. So this includes ultrasound-guided procedures. And however, to ensure minimum competence, we're asking a couple things. The DEM faculty will sort themselves into one of three buckets. The first group is those who have experience with these procedures, possibly from residency or from a previous position. For these people, just watch this video and send me an email saying that you've done so. The next group of faculty is those who have had limited exposure to these procedures. Let me know if you're in this group and we'll have you attend an ACEs session or do a scanning session with me in the department to get you up to speed. Lastly, if this is something that you're not interested in, thanks for watching this video this far, and then let me know if you change your mind at any point down the road. So now we're going to shift into some more interesting content about nerve blocks themselves. Nerve blocks aren't rocket science, but there are definitely a few tools that make the job a lot easier. First and foremost, I want to talk a little bit about the cool features of block needles. Most importantly, the tip is blunted, meaning it's designed to not cut through tissue. This means that you will have to give it a little bit of oomph to get it through the skin, and for this reason, I recommend placing a superficial wheel of anesthetic prior to inserting the needle. These needles will minimize the damage caused to other structures, including nerves, in case you accidentally hit the nerve itself. It will hopefully push the nerve out of the way rather than stab into the nerve tissue. You also will feel a pop as you pass the needle through fascial planes, which is very handy when performing certain nerve blocks such as the fascia iliaca. These needles are made to be echogenic, which means they have small grooves cut into them that allow the ultrasound beam to be maximally deflected even at fairly sharp angles, which will help your visualization during in-plane guidance. These needles have a convenient grip that allows you to comfortably hold them for maximal control. So that means you don't have to fiddle with a syringe or try and pull back a plunger with one hand. Lastly, these needles come with extension tubing already attached. This allows for a two-person block setup where the operator can focus on the probe and the needle while the assistant can aspirate, inject, and change syringes while the operator maintains their location. Like I showed earlier, these needles are in the block box, but if that runs out, you can find them in the supply room at both UH and EMH. At UH, these are on the right side of the supply room as you enter, right next to the spinal needles. Both 100mm and 50mm length are stocked. 50mm is likely long enough for most patients, but you'll definitely care for patients who need 100mm of needle length. At East Madison Hospital, these are stocked in room 1261, which is the supply room across the hall from Pod 5. They live next to the spinal needles there as well. When you're picking your local anesthetic, the main consideration is how long you want the block to last. Lidocaine will give you about an hour of analgesia, which is perfect for an ED procedure such as a laceration or reduction. This also allows you to get a post-reduction neuro exam before the patient leaves the department. Long-acting anesthetics such as bupivacaine or ropivacaine last around 8 hours, which is great when you're aiming for long-lasting blocks for painful injuries such as hip or rib fractures. The caveat with these medications is that they are more lipophilic, so their toxicity is more of a consideration, especially if you are using a larger volume for a plain block. I want to touch on a few best practices. Like we mentioned before, and similar to any other procedure, inserting a needle into the skin carries a risk of pain, infection, and bleeding. There's also a risk to surrounding structures, arterial puncture, pneumothorax, particularly if you're blocking near the lung, or direct nerve injuries. You should discuss all of this in your consent process before the procedure. You also want to set up your machine in clear view so that you can move your vision from the probe to the screen just by moving your eyes. I also think it's key to line up your body with the imaging plane of the ultrasound transducer. This will make it much easier to keep your needle in plane while you're doing your procedure. Once you get your needle into the appropriate location, Like with any injection, you want to aspirate first to ensure that your needle tip is not in a vessel. When you are injecting, stop every 5 cc's or so and aspirate again to make sure that your needle tip hasn't moved into a vessel. You should be able to see your local anesthetic being injected at all times, and if at any point you lose visualization of your needle tip or the pocket of anesthetic stops growing while you're injecting, stop and fix your view before injecting any further. So if we go back to medical school for a minute, nerves are not just a single strand, but a collection of individual neurons and their axons bundled into fascicles. These fascicles are wrapped within the perineurium and then bundled inside a layer called the epineurium. Within the epineurium is connective tissue as well as the vascular supply to this tissue. This architecture is visible on ultrasound and explains why nerves classically have a chocolate chip cookie appearance. Our goal is not to penetrate the epineurium, but to bathe the nerve in local anesthetic that can then diffuse inwards. This is a still of the posterior tibial nerve. Note the chocolate chip cookie appearance that helps to separate the nerve from the surrounding connective tissues, even though it has a similar echogenicity. In this image, we can see the nerve fills the space between multiple fascial planes, and we can use this to our advantage to increase the efficacy and safety of our blocks. So the nerve lives here, and you can see the fascial planes extending out to the right and to the left. Nerves will look differently depending on where you are in the body. As nerves move distally, the amount of nerve tissue compared to connective tissue decreases, making the structures increasingly hyperechoic. The far right image is the median nerve, which is hyperechoic compared to the surrounding muscle. The supraclavicular brachial plexus is isoechoic to the surrounding tissue, and in the image on the far left, the interscalene brachial plexus appears nearly anechoic and could easily be mistaken for a blood vessel. Performing nerve blocks in the ED is overall very safe and much safer than the heavy use of opioids, but there are a couple complications to be aware of. The good news is that these are generally avoidable with the use of good technique. First and foremost, nerves can be damaged from directly stabbing them with the needle or by injecting anesthetic within the nerve itself. Additionally, damage to surrounding structures is possible as nerves tend to run with arteries. Lastly, patients can develop local anesthetic systemic toxicity, which is a potentially fatal outcome of poor nerve block technique. Peripheral nerve injury can be caused by direct damage to the nerve fibers with a needle or by injecting anesthetic within the nerve itself. Intraneural injection can cause ischemic necrosis due to increased pressure within the nerve fascicle, causing compartment syndrome. If I am aiming to block a specific nerve, don't aim your needle directly at the nerve. Instead, identify the fascial plane that the nerve sits within and aim there. When an anesthetic is injected into this plane, it will flow to bathe the nerve while keeping your needle tip away. This way, if you advance too far or the patient moves, your needle will not advance into the nerve, risking direct nerve injury. We do these procedures in plane so that we can be sure that we know exactly where a needle is at all times. This limits potential for inadvertent nerve injury as well as accidental puncture of other structures. In addition, by using blunt tip needles or designated block needles, you also decrease the risk of damage to the nerve compared to if you were using a standard hypodermic cutting needle. The risk to surrounding structures varies depending on where you are in the body. Brachial plexus blocks tend to have multiple high-risk structures surrounding them. These can be blocked safely, but it requires good use of in-plane needle guidance and a cooperative patient to ensure the needle tip goes exactly where you want it. For example, setting up for a supraclavicular brachial plexus block requires identification of the subclavian artery, first rib, and the pleura in order to make sure that you follow a safe path to the brachial plexus. In addition to simply injecting anesthetic next to a nerve, we can also inject a large amount of anesthetic in a fascial plane that will predictably diffuse to hit the target nerves. These are two diagrams of probably the two most common plane blocks performed in the ED, the fascia iliaca plane block on the left and the erector spinae plane block on the right. The fascia iliaca block injects anesthetic under the fascia iliaca and provides pain relief for hip and proximal femur fractures. By using this approach, we get spread to the nerves that innervate both of these areas, and we can stay far away from the femoral artery and vein. With the erector spinae plane block, we tug at the transverse process of the spine, and our anesthetic will travel under the erector spinae and will hit the dorsal and ventral rami of multiple different nerve levels as the spinal nerves exit the spine. For details on each of these blocks, check out my videos posted at Madtown Sano. Using a plane block limits the risk of peripheral nerve injury and damage to surrounding structures, but using a large volume of local anesthetic increases the risk for local anesthetic systemic toxicity. This risk can be mitigated by using good block technique, mainly by keeping your needle out of any vascular structures and by double checking your maximum dose of local anesthetic for every patient. If LAST does occur, rapid administration of intralipid can be life-saving. The dosing for this can be found in the nerve block order panel. This is stocked in both UH and EMH emergency departments. As you all know, we don't practice in a bubble. We've had conversations with all of these groups about this initiative, and in general, they are all supportive. My ask is that when you identify a patient who you feel would be a good candidate for a block that you feel comfortable performing and who will have a consult from either the trauma or orthopedic service, please talk to the resident and let them know you feel the patient would be a good candidate and then involve them in that decision. Additionally, please consider the patient's anticipated clinical course. If a patient is leaving for the OR or SICU shortly, these patients may be better served by allowing anesthesia to do their thing upstairs. However, if you have a hip fracture boarding with you at EMH overnight, please feel empowered to do the right thing for the patient. Alright, that's all I got for now. Please let me know if you have any questions or concerns or if you just want to find a time to talk about blocks.